The concept that we're going to talk about here is tissue perfusion and coagulation, specifically related to sickle cell disease. What is the difference between sickle cell anemia and sickle cell disease? Sickle cell anemia is one of a group of diseases that are collectively termed hemoglobinopathies. And in sickle cell anemia, this is where the normal adult hemoglobin, known as hemoglobin A, is partly or completely replaced by abnormal sickle hemoglobin S, which is, S stands, of course, for sickle. In sickle cell anemia, about 40% of hemoglobin S is present instead of the hemoglobin A. In sickle cell disease, this includes all those hereditary disorders whose clinical, hematologic, and pathologic features are related to the presence of that hemoglobin S. Additionally, someone with sickle cell disease, about 80 to 100% of their hemoglobins are hemoglobin S. So their disease process is quite severe as compared to the anemia, which is only 40% of hemoglobin S. Sickle cell disease is an autosomal recessive pattern of inheritance, and these alleles, gene alleles, attempt to show that. On the left in the blue is the father's gene alleles, and these are called beta chains of hemoglobin. Just so you know, that's where that term's coming from. It's a chain of hemoglobin. And the mother, who is on the right in the kind of peach color, she has gene alleles for the beta chain of hemoglobin as well. If both parents have hemoglobin A and hemoglobin S, then as you can see looking at the downfall here, on the left you have two hemoglobin A alleles. That person, that offspring, will be completely unaffected. They cannot even transmit the disease. In the center are two alleles that have a hemoglobin A and a hemoglobin S, or a hemoglobin S and a hemoglobin A. They are the carrier children. Those children can pass it on to their offspring if they marry and have children with someone who is also at least a carrier. On the far right are the hemoglobin S. These inherited the hemoglobin S allele from each parent, and therefore they actually have the disease. They are going to be dealing with a sickle cell disease for the rest of their life. As you can see, there's a 25, 50, 25% risk of inheritance is what that's basically called. It's a recessive pattern of inheritance. Sickle cell disease, there's the sickle cell trait, and that's, as I said, only one hemoglobin S gene allele has been inherited. It is abbreviated as AS. That's just what you may see it written as AS. Sickle cell trait persons are a carrier and can pass it on to offspring, as you saw. There's a 25, 50, 25% chance of passing it on if they also marry someone with the trait. These persons have more mild manifestations of the disease because only 40% of the hemoglobin is abnormal. So that's the good thing about having just the trait. They may still have episodes, but they will not be at all severe compared to the disease. The sickle cell disease, as you saw, these persons have two of those hemoglobin S gene alleles. So they actually have the disease, and they will have 80 to 100% of the hemoglobin they have in their body is known as hemoglobin S, and that is abbreviated as SS. The manifestations of sickle cell disease are often severe even when the trigger to causation is mild, and we will talk about those shortly. In the person with sickle cell disease, each offspring of that person will have at least that sickle cell trait. So refer back to the previous slide if you want to see that, but disease, you have a chance of passing it on to any offspring, depending on who you marry. Sickle cell disease is one of the most common genetic diseases worldwide. It affects approximately 72,000 Americans, primarily African American population, and it's Hispanics also have sickle cell disease, and there's a lower incidence in other ethnic groups as well. Of the sickle cell diseases, sickle cell anemia is the most common form in African Americans, followed by sickle cell C disease and sickle thalassemia. We are not going to talk about sickle cell C or thalassemia. With sickle cell anemia, this is considered, of course, a chronic illness. You don't get rid of it. The prognosis varies, but most patients will live into their 5th decade, and most of the time children are without symptoms and participate in normal activities without restrictions. The greatest risk is usually in children younger than 5 years of age, and the majority of deaths in these children are caused by overwhelming infection. You might want to remember that. What causes sickle cell crisis in those with sickle cell disease? Anything that lowers oxygen concentrations can cause or will probably cause a crisis in the patient. The pathology of that is the decrease in oxygen causes an abnormal beta chains, those abnormal beta chains to contract and pile together within the cell. They make a big clump and they distort the cell into a sickle shape. These sickled cells become rigid and clump together, which causes the red blood cells to become sticky and fragile. The clumped masses of sickled red blood cells block blood flow, i.e. a vaso-occlusive event. That's what that's known as, a VOE. A vaso-occlusive event will cause further tissue hypoxia, which causes more sickling, which causes more blood vessel obstruction and ischemia, and therefore more hypoxia, and around and around and around it goes. You can see how this is a cycle that continues, can continue unless it's treated properly. Repeated episodes of ischemia cause progressive organ damage from anoxia and infarction, and the tissues that are most often affected will be the spleen, liver, heart, kidney, brain, joints, bones, and retina. The goal is to preserve function in all of those organs. What conditions might cause the cycling to start? Hypoxia and anything that causes that, and the rest of these are going to be caused, may be causations of hypoxia. Dehydration, infection, venous stasis, pregnancy, alcohol consumption. High altitudes will cause a lowering of the oxygen. High environmental or body temperatures. Acidosis, for whatever reason that started. Strenuous exercise can cause that. Emotional stress, anesthesia. The list goes on, and I'm sure you could each add to this list by thinking about it just a little bit. The sickle cell event sequelae, what happens? The sickled cells usually go back to the normal shape when the precipitating condition is removed and oxygen level returns to normal and proper tissue perfusion resumes. However, some of the hemoglobin will remain twisted, which decreases cell flexibility. Cell membranes are damaged over time and cells are permanently sickled. The membranes are then more fragile and more easily broken. The average lifespan of a red blood cell with 40% or more of hemoglobin S is 10 to 20 days, compared to the 120 days lifespan of a normal red blood cell. This results in what's known as hemolytic anemia. This is a great graphic showing the sickle and comparing the sickled cells to the normal red blood cell. The clinical features, as we've mentioned, of sickle cell anemia are primarily the result of obstruction caused by the sickled red blood cells, vascular inflammation, and increase in red blood cell destruction. The clinical manifestations occur primarily as a result of obstruction caused by the red blood cells and an increase in red blood cell destruction. So if you look here, I get to play with my little drawer. These are nice round cells. I cannot drop. It's fun to play. It's like Etch-a-Sketch. Anyway, these are nice round cells. They could swim through, fly through, go around the curves, no problem. Whoop, out it goes. Whoop, easy peasy. And the normal hemoglobin are in there, just all nicely saturating this red blood cell. However, if you have an abnormal sickle red blood cell, the lack of oxygen causes these to decrease, they flatten, they sickle, they poop down, they become, and they stick. They don't fly through anything, they stick. The big clump here sticks together. And this is the abnormal hemoglobin forms strands that cause the sickle shape. You see that there? Just kind of like adhesions. It's not what they are. It's a hemoglobin strand, but yeah, that's the abnormal hemoglobin. Situations that can precipitate sickling. We've mentioned some, but I'm going to mention just a few more. High fever, dehydration, emotional or physical stress, any condition that increases the need for oxygen or alters the transport of oxygen can result in sickle cell crisis. Sickle cell crises are acute exacerbations of the disease, which vary considerably in severity and frequency and include those vaso-occlusive crises, splenic sequestration, hyperhemolytic crisis, and aplastic crisis. We'll talk about each of those next. A vaso-occlusive crisis is caused by stasis of blood, excuse me, with clumping of cells in the microcirculation. Ischemia results in infarction. So as the blood clumps, those cells clump, it will cause tissue damage and infarction and more hypooxygenation. Manifestations related to ischemia of the involved areas will be exhibited such as following. In the extremities, they will have a painful swelling of hands and feet, painful joints. The actual joints over time get necrotic and the pain gets worse with time. The abdomen they will have severe pain resembling acute surgical condition. It can mimic appendicitis. So it's important for us as nurses and for, of course, physicians as diagnosticians to know the difference between abdominal pain due to sickle cell crisis in the abdomen or what is appendicitis. How does that exacerbate? So it'd be good to know the difference between those two. In the cerebrum, stroke and visual disturbances can occur. There is something called acute chest syndrome, and this will result in symptoms that resemble pneumonia. They'll have chest pain, fever, develop shortness of breath, rapid breathing, and a cough. So if you have a sickle cell positive patient in your care and they start developing symptoms, then you go, oh, I wonder if he's got pneumonia. Your next thought should be, or could he have acute chest syndrome? Liver obstruction there can cause obstructive jaundice. They can show signs of jaundice and hepatic coma if it becomes severe enough. Now, in a dark-skinned person, jaundice will be able to be seen in the sclera of their eyes. Look at the roof of their mouth. That's where you're most likely to see the jaundice discoloration. If your sickle cell patient gets hematuria, be worried about that kidney. Okay, the kidney is also subject to vaso-occlusive crisis, and as it shuts down production of urine, you're going to start getting hematuria as the cells in the kidney get destroyed, become damaged. In male genitalia, priapism is known as a painful penile erection, and that can last for days. It's a very painful situation. And depending on the age of, well, anybody, any man, you can imagine the embarrassment that may be, but truly the priority there is treating the pain. It hurts terribly. Sequestration crisis is caused by pooling and clumping of blood in the spleen. It results in hypersplenism. The manifestations of this would be profound anemia, hypovolemia, and circulatory collapse resulting in shock. So know your symptoms of shock. Hepatomegaly and splenomegaly, of course, will happen. It often requires a splenectomy, which puts the individual at further risk for infection. So anything that causes infection causes an increased risk of sickle cell crisis. The hyperhemolytic crisis, basically that is an accelerated rate of red blood cell destruction. And what we'll see in those patients is, again, anemia, jaundice, hematuria, and reticulocytosis, which you'd see on lab results. So lab work is very important in these patients. They would be treated with a blood transfusion, and we need to support their liver and kidney functions. Aplastic crisis is caused by diminished production and increased destruction of red blood cells triggered by viral infection or depletion of folic acid. So you can see why maintaining health and nutritional support is important. They will also have profound anemia and pallor, and again, they would also be treated with a blood transfusion and oxygen. Clinical manifestations of sickle cell anemia, things that you'd want to look for as you do your assessment. The sickling response is reversible under conditions of adequate oxygenation and hydration. So very important to catch this early to preserve those red blood cells. However, after repeated sickling, the cell becomes permanently sickled. It cannot come back to a round shape. The general health concern in these people, especially the children, is possible growth retardation, chronic anemia, hemoglobin level of 6 to 9 grams per deciliter, very, very low. Imagine all the symptoms associated with that. Increased risk of getting infections. You're exhausted, fatigue, the lack of muscle tone, so many things as a result of that. They may also have delayed sexual maturation, which has not only a physical aspect to it, but also the social aspect for these pubescent children. They also have a marked susceptibility to sepsis. Must really guard them away from getting infected. A multidisciplinary approach to care is needed, and care focuses on prevention and treatment. Preventing by preventing exposure to infection and maintaining normal hydration, and treating them by hydration, oxygen, pain management, and bed rest of the crisis. Management of sickle cell disease, we prevent the infection. There's a use of prophylactic penicillin in these patients, and making sure they get their proper immunizations to prevent from severe contagious diseases. Screen for related health problems or height, weight, blood pressure, oxygen saturation. You can see how a hypertensive would have even more problems with sickle cell crises than a normal tensive patient. So keeping their blood pressure, their weight under control. Labs related to that kidney function. One of the things I've always told students, if I've got urine coming out that looks good, I'm happy girl, I'm a happy nurse. Those kidneys, if I have a good working kidney, I have a lot of reserve in my patient. We have a lot of time to fix whatever's going on. But once that kidney starts showing a decrease in function, we are starting to hit the wall. Eye examinations to look for any problems in the retinal area, and then transcranial ultrasound Doppler to screen for strokes. This is the NIH government on health topics. You may want to refer to that. It is very important to advise parents to be particularly alert to situations in which dehydration may be a possibility, such as hot weather. You know, if you're a child, we want kids to be outside playing. I mean, that is preferable to them sitting inside on a video game. But understand that the sickle cell child has that increased risk of dehydration and must be taught to drink a lot when they're outside playing. For every 20 minutes of activity, drink a glass of water or a Gatorade. Keep that hydration factor up to prevent a crisis. Recognize early signs of reduced intake, such as that decreased urinary output. Now here in the baby, fewer wet diapers. That would be the indicator. For a child that's active, that's outside, it might be a little harder to track that. So it's important to really have that child be involved in the care management by understanding the importance of letting you know when he's going to the bathroom, and of course increased thirst is early. Increased thirst is actually a late sign of reduced water intake, so that's kind of late, but go ahead and drink. Must be treated immediately to prevent acute pain in sickle cell crisis, and the children can learn that. Pain is the most common symptom of sickle cell disease crisis. Other manifestations vary with the site of tissue damage. Acute pain episodes have a sudden onset and usually involve the chest, the back, abdomen, and extremities. Please know that opioid addiction is rare in these patients. We emphasize the need to treat for pain, and Motrin, while it can be useful, it is not going to help these severe cases. They need opioid. They need a stronger pain medication for treatment. And I know how important it is to be cognizant of the opioid epidemic in our country, but that should not prevent us from treating these patients with the drugs that they need to treat their pain. The priority problems for the patient with sickle cell disease are acute pain related to the poor tissue oxygenation, chronic pain related to joint destruction, a potential for sepsis, and the potential for multiple organ dysfunction and eventual death. For acute pain, when an acute crisis is just starting, most doctors will advise the person to drink lots of fluid and take a nonsteroidal anti-inflammatory such as Motrin or ibuprofen. If a person has kidney problems, though, acetaminophen is preferred, not the Motrin. If pain persists, many people will find that they need a stronger medicine such as the opiate. Combining additional interventions such as massage, relaxation methods like heating pad, I would think warm baths would also help. If a person with sickle cell disease cannot control the pain at home, he or she should go to a sickle cell disease day hospital outpatient unit or an emergency room to receive additional stronger medications and IV fluids. Administration of Demerol for pain is avoided because of the risk of Demerol-induced seizures. I cannot say it. Normoparidine-induced seizures. Okay, so we don't use Demerol. I would even encourage these patients to wear a wristband that said sickle cell disease patient, so that when they do, if they do go to the ED department, they're not being looked at as narcotic seekers. CHOA has a protocol for pain management for their sickle cell disease children. They use hydrocodone, acetaminophen combination, 0.2 milligram per kilogram, not to exceed 10 milligrams of the hydrocodone. Intranasal fentanyl is always used. That would be 2 doses given 5 minutes apart, 1.5 micrograms per kilogram per dose, not to exceed 100 micrograms of fentanyl per dose. That would be administered equally between the nares, and use a mucosal atomizer device, or MAD. Do not administer to younger than 2 years age or older than 18 years. If pain is greater than 5 on the pain scale, may also administer Toradol, 0.5 milligrams per kilogram IV. The maximum dose to be given would be 30 milligrams. We do not use Toradol on a patient who's had ibuprofen in the last 4 hours, however. It cannot be emphasized enough how important it is to maintain adequate hydration in these patients. Maintaining adequate hydration and blood flow through oral and intravenously administered fluids is vital. Without adequate hydration, pain will not be controlled. Electrolyte replacement is also provided as needed. Administer oxygen and give blood transfusions as prescribed to increase tissue perfusion and maintain tissue function and decrease pain. Exchange transfusions may also be prescribed, and these would reduce the number of circulating sickled cells and therefore reduce the risk of complications, and also administer antibiotics as prescribed to prevent infection. Administer analgesics as prescribed around the clock. These are not to be PRN. These are to be routine, regulated, around-the-clock pain medications. Assist the child to assume a comfortable position so that the child keeps the extremities extended to promote venous return. Elevate the head of the bed no more than 30 degrees. Avoid putting strain on painful joints and do not raise the knee gatch of the bed. Encourage consumption of high calorie, high protein, and folic acid supplemented diets. Monitor for signs of complications such as an increase in anemia. What are you going to see with that? More pallor, slower, even slower circulatory capillary refill time. So monitor for that, for decreased perfusion, and for symptoms of shock. And those would be your vital sign changes, mental status changes. All of them are very important in evaluating your patient's status each shift, if not more than once a shift. Every time you go in the room, pay attention to the mental status. Instruct the child and parents about the early signs and symptoms of crisis and the measures to prevent the crisis. Ensure that the child receives the pneumococcal and meningococcal vaccines, the annual flu vaccine because of susceptibility to infection, which is secondary to functional asplenia, not a healthy spleen. A splenectomy may be necessary for clients who experience recurrent splenic sequestration, and the parents must be informed of the hereditary aspects of this disorder if they do not already understand it. Hydroxyurea is an oral medication that's been shown to reduce or prevent several sickle cell disease complications. So it's good we need to talk about this for a minute. This medicine was studied in patients with sickle cell disease because it was known to increase the amount of fetal hemoglobin, which we haven't mentioned yet, but hemoglobin F is fetal hemoglobin, and hydroxyurea will increase the amount of hemoglobin F in the blood. Increased hemoglobin F will provide some protection against the effects of hemoglobin S. Hydroxyurea was later found to have several other benefits for a person with sickle cell disease, such as decreasing inflammation. The use in adults, many studies of adults with hemoglobin SS or hemoglobin S, the B thalassemia, showed that hydroxyurea reduced the number of episodes of pain crises and acute chest syndrome. It also improved anemia and decreased the need for transfusions and hospital admissions. Its use in children showed that children with severe hemoglobin SS or B thalassemia showed that hydroxyurea reduced the number of those vaso-occlusive crises and hospitalizations. A study of very young children between the ages of 9 and 18 months with hemoglobin SS or the thalassemia trait also showed that hydroxyurea decreased the number of episodes of pain and dactylitis. How is hydroxyurea taken? It's taken by mouth daily at the prescribed dose. When a person does not take it regularly, it will not work as well or it won't work at all. A person with sickle cell disease who is taking hydroxyurea needs careful monitoring. This is particularly true in the early weeks of taking the medicine. Monitoring includes regular blood testing and dose adjustments. So they would need to be educated about that. Yes, there are risks. Every time you take a drug, there's a risk. Hydroxyurea can cause the blood's white cell count or platelet count to drop. In rare cases, it can actually worsen anemia. These side effects usually go away if a person stops taking the medication. When a person restarts it, a doctor usually prescribes a lower dose. Other short-term effects are less common. There has been shown that a use of hydroxyurea is associated with an increased incidence of leukemia, and it suppresses bone marrow function, which including immunity. So it does have some risk factors there. Best practice, to sum it up: genetic counseling prior to pregnancy. Parents must understand the risk. Teach symptom prevention strategies, which you should now know. Manage the pain, which you should now know. And prevent and detect and treat infections early. And that is sickle cell disease.